Yes, thank you very much for the invitation. And I quite enjoyed the talk by Dr. Dan, and it was quite a lot of interesting points. I'll be talking about correction of forearm supination deformity in children with birth brachial plexus palsy. So there is a lot of things written about the shoulder indication for surgery in birth palsy, but forearm has attracted much less attention. However, if we see a patient could develop a supination deformity or a pronation deformity. Though pronation deformity is not so uncommon, but still it is much less indication for surgery because supination deformity is the one which is more bothering functionally and aesthetically. It is quite a contrast when you think a child with birth palsy is generally referred to as a waiter's tip hand, where the hand is pronated, and as they grow up, they develop a supination contracture. So this is quite a contrast, but supination deformity is almost 9 to 10 times more common and indication for pronation deformity. Why is it so? Because the supination deformity gives a very awkward position to the hand. See the child of this kind, a right upper limb involvement, the hand is facing forward. And this deformity has been termed by Al-Qatan as beggar's hand, just to give a very bad, awkward posture to the upper limb. And an unshakable hand because the child would not be able to go and shake a hand to anyone he wants. So this immediately attracts an attention of anybody who is seeing the child and gives a very awkward look to the upper limb. Not only the cosmesis, functionally also this deformity is quite a problem. You see a child with a supination deformity, if he tries to lift an object from the table, he has to struggle a lot to reach to that object. The struggle is more because these children have very poor shoulder function, and the child has to make a lot of effort to reach to a simple object which is lying on the top of the table. Also, if they want to reach mouth, again the movement is quite difficult because the wrist is hyperextended. Even a simple task of just turning around the page also is difficult for these children with this deformity. So it is not only the cosmetic concern, it is also a functional problem. When we see a patient with supination deformity, they generally have this combination of deformities. They will have a poor shoulder function. They have weak triceps, resulting in an elbow flexion deformity. They have weak wrist flexors, resulting in an extension posture at the wrist. They have weak finger extensors. So weak triceps, weak wrist flexors, and weak finger extensors. This is the usual combination, and the deformity itself places the thumb in an adducted posture of this kind, which further decreases the function of the thumb. So these all deformities lead to much more functional disability of the hand than what a motor deficit would dictate. Hence, a simple correction of the deformity would itself result in improvement of the function. Now, when we correct these deformities, what we are going to achieve with that. So parents are always very keen to find out what improvement you are going to get. Actually, the immediate improvement what a child would get is immediately the hand would start looking better. On the left side to right side, that tremendously improves the confidence of the child. Second thing is the patient would have improvement in tabletop activities. When hand is pronated, it would straight away able to go and pick up objects lying on the tabletop. So when we plan operation for correction of supination deformity, there are three main important considerations. The first one being, we should confirm that the child has a good wrist extension, at least grade 3. You imagine a child over here who has a supination deformity, but when we check the wrist extension, the child does not have wrist extension. So if the wrist extension is absent, if we correct a supination deformity to get a pronation posture, the child will develop a wrist drop. A dropped wrist is more of an aesthetic and functional problem than a supination deformity. So one must confirm that there is a good amount of wrist extension before we proceed to correction of supination deformity. We should see whether the deformity is passively correctable or a fixed one. A passively correctable deformity is a candidate for tendon transfer, whereas a fixed deformity would require a bony correction. The third is to know what is the triceps power. Because one of the common operations to correct the supination deformity is biceps rerouting, which is relatively contraindicated when triceps is weak. Because in presence of weak triceps, if we do a biceps rerouting, children tend to develop a severe elbow flexion deformity. So once we know all these three aspects, we could plan the type of correction we do for supination deformity. And this is our general plan. So a patient with supination deformity, first thing to find out is whether it is passively correctable or a fixed deformity. If it is passively correctable, we have options of doing tendon transfers. The good thing about tendon transfers is it is going to restore movement in both the directions. Whereas an osteotomy is only going to change the arc of movement. It is going to decrease the range, but it will convert the range to a more functional range. So first preference is tendon transfer, but if a patient is not candidate for that, we need to go for osteotomies and corrective operation, bony operations. Among the tendon transfer, there are two options, biceps rerouting and brachioradialis rerouting. If the patient has got a good triceps function, then he is a good candidate for biceps rerouting. If the triceps is weak, we select to do a brachioradialis rerouting. If the deformity is fixed, or if there are no suitable donors, we straight away go for radius pronation osteotomy. So this is the generalized plan. So I would give some examples of each of the three categories, and we can discuss then how to plan it out. This is the situation one in which the deformity is passively correctable in a 3.5-year-old child with good triceps function and good biceps function. We took him for biceps rerouting, which is incidentally described by the senior Zancolli, and happy to see his grandson moderating this session. The procedure basically involves cutting the biceps in a Z fashion. The distal slip is taken through the interosseous membrane around the radius and sutured to itself in such a way that it is going to give a pronation torque now. And this is the outcome we got in a child at 2 years follow-up. See, good amount of supination. She is able to do a pronation of around 30 degrees. So from a pre-op stage of no pronation at all, we reached to a 30 degrees of pronation actively. And we retain good amount of supination. That is the advantage of doing a tendon transfer operation. Second situation in which the triceps is weak, it is only grade 2. Hence, we didn't want to do a biceps rerouting. Because if we do biceps rerouting, it tends to become tight and the elbow flexion deformity could increase. So here we selected brachioradialis rerouting, which was described by Ozkan. Incidentally, I saw in the Zoom group, Dr. Ozkan also has logged in, I think. So you'll be happy to see we quite often use his operation. And this operation, interesting thing is you can take the distal part of the brachioradialis, which has been cut in a Z fashion, either through the interosseous membrane or through outside to interosseous membrane. And you can achieve either pronation or supination just by changing the direction of rerouting of the tendon. In this case, we reroute in such a way that you induce a pronation torque at the forearm. In such a way, and this is the outcome at 2 years follow-up. Patient recovered about 20 degrees of pronation. The pronation recovery with brachioradialis rerouting is a little bit less than what you get by biceps rerouting, but it is good enough to allow day-to-day activities and add to satisfaction of the patients. So from pre-op, no pronation at all, to a post-op of 20 degrees of pronation. However, the commonest is the situation 3, where the deformity is not passively correctable. That mostly because most of our patients present when they are above 5 to 6 years of age, and at that time, most of the times the deformities are quite fixed. And also often you don't have a donors to correct the deformity. So we have to resort to bony operations, the commonest one being an osteotomy of the radius. So radius osteotomy is done at the middle third, lower third junction, and the radius could be hand is rotated to the desired position. it gives the immediate effect. You see a patient with fixed deformity over here, and straight away the hand starts looking nice. That is associated with an immediate satisfaction among the parents. It also improves function. On the left side pre-op photo, the child having a lot of difficulty in picking up an object. But after osteotomy, just because the hand is placed in better position, she is straight away able to go and lift up an object. So tabletop activities are dramatically improved. What outcome can we expect after doing a corrective osteotomy? First of all, we get a better appearance, which I think is one of the very important aspects, especially when the children are growing, they have a lot of esteem related problems and they want to look better. And that gives an immediate satisfaction to them. Second thing is the tabletop activities improve. On the left side, the same child whose video we saw and he was struggling to go and pick up an object from the table. Just by placing the hand in a better position by the pronation osteotomy, hand straight away goes and pick up an object. So the tabletop activities are dramatically improved. Children are able to reach more comfortably to the center of the body. They are even able to reach much easily to the mouth in mid-prone position, not in full supination, but in mid-prone position. So they are able to eat some snacks with the right hand. A word of caution, the parents have to understand that after an osteotomy, the full supination movement will not be possible. So if there are some social customs related to full supination position, as we see in India, where many of the people want to eat with hand, and eating with hand requires full supination. So parents must understand that after an osteotomy, the terminal 40 degrees of supination would be lost. And if they understand that, then they can expect a good appearance of the upper limb and improvement in all the desktop and tabletop activities. To conclude, forearm deformities are quite common. Supination deformity is much more a surgical indication than a pronation deformity. And most of these patients actually fall in the category that you will require to do a surgical correction. Patient selection is very crucial as the parents have to understand what the outcome they are going to expect. Forearm correction, it does not add any extra power to the hand, but just by placing the hand in more functional position, children dramatically improve in their overall day-to-day activities. Improved appearance has the more social impact and children, and which is very so important for the child's overall development. So just by a simple operations, we can correct and change an unshakable hand to a shakeable hand and a beggar's hand to many of the happy hands. Thank you very much.
Thank you, Dr. Praveen. This was an excellent talk. And thank you, Dr. Soldado. And congratulations for 1 year with these great talks. So we have a lot of questions in the chat. So means that the talk give a lot of thoughts. And first of all, as a concept, we have that this kind of supination deformities are in patients that they recover part of the upper roots, but they don't have the C7, C8, T1. And they have this deformity because the biceps recover and the supinator recovery. Is that correct, Dr. Praveen?
Yeah, you're right. So supination deformity would be more seen in a global palsy patients who have recovered upper part of the plexus. So they have C5, C6 recovery, but C7, C8, T1 have not recovered much. And since biceps has recovered earlier than triceps and hand, the hand forearm goes in supination posture.
So one question before going to the chat questions is, what do you consider the ideal age to put the hand in a good position? Because I always think if a kid has the forearm in supination and the hand is not in a pronation and in a good position in order to put the sensation to objects, it won't develop cortical brain in order to use more the hand. So what do you think is the ideal age to do this procedure?
So that is the good thought about the sensation and their cortical development. But I think the best age for doing this operation is when the child has recovered whatever we expect from the spontaneous recovery or whatever operation we have done, and it will correspond to somewhere around 3 to 5 years of age.
Perfect. Thank you. Um, One of the questions in the chat says, how do we assess the brachioradialis? Usually we do elbow flexion in neutral position of the forearm against resistance, and we will see the brachioradialis contracting. That is how we do. Do you do the same?
Yeah. So we put the forearm in mid-prone position and check for resisted elbow flexion.
Yes.
That is a good question because many of these children do not have passive pronation possible. They have a fixed supination deformity.
Yes.
So it is at times quite difficult to check brachioradialis for them. But actually, we are using brachioradialis only for a passively correctable deformity. And in those patients, we will be able to assess.
Yes.
Resisted elbow flexion in a mid-prone position.
Perfect. So it says if we use EMG, we don't use usually EMG to evaluate this.
We don't use EMG. It is only clinical assessment. Because we are going to transfer this tendon, if you require to assess the muscle by EMG, that means the muscle is not good enough to do a tendon transfer.
Yes. There's something interesting that when we check the brachioradialis, there's also a little contraction of the triceps. And in these kids, we use the brachioradialis when we don't have a good triceps in order to avoid. So it is kind of different to tetraplegic patients in this kind of kids. The other question, Dr. Soldado, in biceps rerouting, what percentage of patients they lose supination?
Yeah. So when you are doing a biceps rerouting, child would have decrease in supination to about maybe around 30 degrees of supination would decrease, but they still retain enough supination to reach to their face and mouth for their day-to-day activities.
Yes, perfect. And in very supple forearms, do you see a lot of pronation deformity, severe pronation deformity, or no?
No.
No. Is
You mean
because,
after correction?
yes.
Yeah. So after correction, we don't see much. We have not observed any of very severe pronation contracture.
Also, the supinator is working, so it helps to keep this balance, I believe.
Okay.
The other thing, I like very much your talk. Do you consider the interosseous membrane? Because we can have a supple forearm or a fixed forearm deformity. And that fixed forearm deformity can be because of two things, interosseous membrane contracture, or when we have problems at the joints, PRUJ or DRUJ. So usually in these fixed deformities, we take x-rays to check the joints. And if the joints are congruent, we think that the interosseous membrane is part of the problem. So we can release the interosseous membrane and do a biceps rerouting. Do you think the same, sir?
Yeah. So that is a very good thought and a very complex decision at times. I agree. There is a big group of patients who would be there in between category where the forearm is stiff, but it is not totally fixed. So what I personally think is if there is a dislocation, then it is obvious that the problem is much severe, and then we cannot do anything of the interosseous membrane release so that to get increase the range. So for me, preference of doing an interosseous membrane release is only for the patients who have just springiness towards the end of their range of movement.
Okay.
So if the forearm rotation is stiff throughout, even interosseous membrane release will not work well, because even if you do interosseous membrane release and tendon transfers, those children don't do very well.
Okay.
So I add interosseous membrane release to a tendon transfer only if there is springiness towards the end of the rotation, not throughout the rotation. If throughout the rotation is tight, then we label it as a fixed deformity.
And you go to the osteotomy, correct?
Osteotomy.
So
And
we
just to
have
add to one point, if
yes.
there is a dislocation of the radial head, you would agree it is one of the very difficult things to do. So if there is an anterior dislocation of the radial head and you are doing a supination deformity correction, in a young child, I would transfer the biceps tendon from the radius to ulna, because by doing the translocation of radius to ulna, you prevent recurrence of the deformity.
That's a good point, sir. So we have another question there that it says, how do you calculate the amount of rotation for the radius osteotomy?
Yeah, that is a great question. So a very practical one. So two things. So first, we need to find out what is the status of wrist flexors. So if wrist flexors are good, then the aim is to place the hand in mid-prone position.
Yeah.
So you see what is the pre-op posture and aim to get to a mid-prone. But if the wrist flexors are weak, then we would like to place the forearm in 30 degrees of pronation. Why so? Because when you place the hand in 30 degrees of pronation, the patient can use gravity to let their wrist fall, and they already have wrist extension. So that way, they are able to get both extension and flexion just by placing the forearm in a better position. So if the wrist flexors are good, you aim for mid-prone. If the wrist flexors are not working, then you get to 30 degrees of pronation. And another important technical point is many of these children would have a passive hypersupination deformity. So that also we should take into account when we are doing correction. So normally we would believe that if you want to get to mid-prone, you are maximum requiring to do a 90 degrees correction. But many children would have a 30 degrees of hypersupination. So we need to add that 30 to 90 and correct 120 degrees.
Good point.
So those are two, 3 points which we need to take in account to decide how much correction is required. And if the correction is more than 100 degrees, we need to be prepared for doing an ulnar osteotomy as well.
Yeah, to combine osteotomies. One question. You said that, of course, it's very important in the assessment of the patient to check if they have wrist extensors in order to do this osteotomy or these transfers to get pronation. What happens when they don't have wrist extensors? Which is your preference?
Yeah. So if they don't have wrist extension, so one thought is you can do a pronation osteotomy and tendon transfer at same time. But many of these patients do not have good donors.
Yes.
So, and if your tendon transfer fails, then you will have a wrist drop. So to be on safer side, it is always good to first do a tendon transfer, make sure that you get an active extension of grade 3, and then do the pronation osteotomy at second stage. But if no tendon available, then you have to resort to going for a wrist fusion.
Yes. One question. Usually with these kids with supination deformity, they also have ulnar deviation of the wrist. Do you see this, sir?
Yes, very often.
Do you do
We have
something to
published,
correct?
yeah, so we have published a small paper on that. So whenever we are doing a correction of supination deformity, we often add ECU to the ECRL or abductor pollicis longus transfer. So we transfer the ECU to ECRL just to balance the wrist and get it into the center.
You know,
So that can be done along with osteotomy itself.
yeah, you know, for that ulnar deviation, my grandfather described, you take the ECU, you pass it through the interosseous membrane under the radial bursas so that will also help to give you not only correct the ulnar deviation, but also help to get pronation because of the changes of the direction of the tendon.
Yes, yes, I have read the paper. I have quoted this in our article. It is a nice one.
So, well, I think maybe we can go to the next talk.
Thank you very much. Incredible talk, incredible moderation. Thank you very much.